Good evening, everyone, and thank you to everyone who's joining us on Zoom and on Facebook this evening. I'm Ashley Shaw. I'm the Medical Director here at Cambridge University Hospitals, and I'm really pleased tonight to have two fabulous speakers, Professor Sharon Peacock and Chris Smith. So for those of you who don't know Sharon is one of our non-executive directors here at CUH. She's a professor of public health and microbiology in the Department of Medicine at the University of Cambridge. And she's an executive director and chair of the Covid-19 Genomics UK Consortium, COG UK, and is on secondment to Public Health England as the Director of Science for Pathogen Genomics. Truly national leader in the field of genomics and viral infection. And Dr. Chris Smith, who's a medical consultant specializing in clinical microbiology and virology here at Addenbrooke's and for Cambridge University. He's also the founder of the Naked Scientists, which is based at Cambridge University's Institute of Continuing Education. That's a team of scientists, doctors, and communicators whose passion is to help the general public to understand and engage with the worlds of science, technology, and medicine. And many of you will be familiar with his work on TV and radio, I'm sure. So what we've done this evening is we've posed the question to both of these presenters. What next in the world of COVID-19 pandemic? What next in the world of the COVID-19 pandemic? And Sharon and Chris are approaching these from different angles. So first of all, we'll hear from Sharon and then from Chris. And then we'll move on after the second presentation and take questions. So we'll take questions. And if you do have questions at home, you could, and you're joining via Zoom, you can put them in the Q&A box. We've disabled the chat box, otherwise it becomes completely impossible for me to be able to concentrate on anything. So if you're on Zoom, put your questions in the Q&A box. If you're on Facebook Live, type your questions into Facebook comments. And as they say on the TV, if you're watching this as a recording, don't type your questions in anywhere, because they just won't be answered. Okay, so without further ado, I'm going to hand you over to Sharon to give her first presentation.
Thank you so much, Ashley, and thank you so much for inviting me. It's an absolute pleasure to be here this evening. So my slides are just going to be put up on the screen by Nikki. So thank you very much. As you've already heard, I direct a group of people, a consortium called the Covid-19 Genomics UK Consortium. So this is a screen grab from the front of our website. And so far we've sequenced more than 350,000 viral genomes from people with Covid-19, which is around half of the world's genome sequencing data. And so I hope we're producing a lot of data for the country so that we can guide ourselves through the pandemic and out the other side. So my talk really is about SARS-CoV-2 is mutating. What does that mean for us? Next slide, please. So just to tell you a little bit about the consortium, or COG UK as we call it, just for interest, there are 16 regional sequencing sites and our central hub, which is at the Wellcome Sanger Institute, just up the road from here. We also have 4 public health agencies that work with us in England, Scotland, Northern Ireland and Wales. And project administration is done here in the University of Cambridge. We have £32 million of funding so far to provide the sequence data that we do. Next slide. So first question. How often does SARS-CoV-2 mutate? Well, it mutates around once or twice a month. A given virus will mutate around once or twice a month. Now, that's around half of the mutation rate of influenza, and about a quarter of the mutation rate of HIV. And that doesn't sound very much, but actually there's a couple of things just to point out to you there. The first is that actually there's around 120 million cases of COVID-19 that we know about on the planet. And mutations only occur in the context of somebody who's infected, the virus replicates in the cells, and that's an opportunity when a mistake can be made in the genome of kind of the future viruses that are being produced. So a mutation just really means like a typo in the genetic material. So even though it sounds like it's not very much, the number of cases that have occurred on the planet is very high, so there's lots of opportunity to mutate. And furthermore, what I'll go on to talk about is the fact that it's not so much how often mutation occurs, but where it occurs in the genome and what impact that has on the way that the virus behaves. Now, another question I'm often asked is, why do they occur? Well, it's completely random. So mutations occur across the genome. There are about 30,000 different points in the genome where mutations can occur. It's a random process. But the things we worry about are those that are selected out that make the virus a fitter version of itself, which I'll talk a bit more about in a moment. So, and I'll also be talking about what that means for us. But this particular figure shows what happens when a virus mutates. So actually, more often than not, in almost all cases, the mutation in the virus genome has no effect on the virus. It's a neutral effect and no apparent change in the way that the virus behaves. Now, some mutations in the genome will actually have a disadvantage to the virus and actually will mean that that virus actually doesn't persist. We may never see those mutations at all. But what we're really interested in here tonight are those mutations that give the virus an advantage and might lead to what we call lineage expansion, which means you see many more infections occurring actually with that particular type of virus. Next slide, please. Now, when we think about lineage expansion, that is likely to be due to a particular feature of the virus mutation that really leads to a fitter version of that virus than it already is. And a fitter version will often mean that it can transmit more, or it can have some sort of immune evasion, i.e. we develop an immune response when we have a vaccination or we have Covid-19. And natural selection would mean that particular characteristics such as immune evasion would be selected for, and that's what we're seeing at the moment. This lineage expansion process can also be through a chance event, but I won't be talking about that any further today. Next slide. So what sort of things do we actually worry about when a mutation occurs? Well, there are really 4 features that we're looking out for all the time. The first is that the virus can become more transmissible. It spreads between people more rapidly than previous types of virus that are circulating. The second I've talked about, and that is that the virus could evade our immune system, either from vaccination or previous infection. The third is that this could cause the virus to become more severe disease. And the fourth is that some mutations actually lead to problems with our testing for COVID-19. We're also looking out for those. Now, you will have heard probably in the news that we use 2 terms to try and describe what's going on here as the virus evolves and mutates. One is when a variant, that really means the full entirety of that genome and all of the mutations in it, is of concern to us. That may mean that the virus has a particular characteristic, a particular mutation that we know is associated with transmission, although we can't be certain about it in that particular lineage. So we start to get worried and we start to investigate that particular variant. The second term you will hear is variant of concern. That's where we have strong evidence that there's a particular feature of that virus that we are quite concerned about. Next slide, please. Now, on the gov.uk website, Public Health England produced twice a week a table of the variants of concern or variants under investigation. And this table isn't particularly there to read because it's actually very small print, but just to say that as of yesterday, there were 4 variants of concern. The top one in the row is the one that is the so-called, sometimes called the Kent variant. We call it B117. That's its name in the family tree, and that's the overwhelming cause of disease in the UK at the moment. The others are less frequent. I'll come back to those in a moment. Next slide, please. So really, what I want to do is explain a little bit more about the variant that we have in this country. Now, you will have heard that actually it first emerged in Kent towards the end of November, and it became clear that cases in Kent were beginning to surge, despite the fact that the areas was in lockdown, and in other areas there was no surge in cases. And that was started to attract attention by Public Health England, by ourselves. And what we know now is that this particular variant has 23 different genetic changes in its genome, which is actually a lot compared with other variants. And we call it B117 because actually that's the way we characterize as in the family tree. So in the middle figure there, you can see a very, very small family tree, as it were, of the genomes all lined up together. And the 117 is in the green. It's actually quite different from other circulating viruses. Now, why is this particular variant of concern? Well, first of all, it is more transmissible, probably around 50% more transmissible than previous circulating variants. And in part as a result of that, it's a very fit virus that's outcompeted other viruses, and it now causes around 98% of all cases of COVID-19 in the country. So it spread to the four corners of the United Kingdom. We also consider it a variant of concern because this particular variant actually leads to a very small increase in the severity of disease that people suffer, so they are more likely to go to hospital. But the good news is that there's no change to the vaccine effectiveness against this particular variant. And so although this spreads more rapidly, we can control it through a vaccine rollout. Next slide. Thank you. Now this is a picture just to demonstrate how variants actually change in the country over time. It's a very dynamic process. So each of these colours represents a different variant that has been introduced into the country over time. So the beginning of the image really starts around February of 2020 and goes right the way through to the current time. Now what you'll see here is that it's a very dynamic picture in the first half of the pandemic. Each of those blocks of colour is a particular variant that's been circulating, and you can see that any given week is actually very varied. Until about August, when we see a particular variant coming into the country that actually was introduced from Europe, probably through travel. And so this is a travel-related expansion of this particular variant, actually that had no particular features about it that made it more transmissible or more lethal or had any effect on vaccines. But I'd like you to look at the top green block now towards the right of the picture, labeled B117. And what that shows you is that this particular variant has become completely dominant in the country at the moment. Next slide, please. I think this is my last slide. Just to say that the other variants of concern, going back to the table, in particular, are those first detected in South Africa and in Brazil. So that's the second and the third red block you can see down there. But the good news is that there are a very limited number of those particular variants circulating in the country. It's largely our Kent variant that is circulating at the moment. But it's a very dynamic picture, and every day or every week, a new variant is described in the newspapers, and that is because variants will occur all around the world. Mutations are going to happen in the four corners of the globe, and this is something that will keep happening. We can come back to that and what the implications of that are in our questions. But I wanted to leave you with some key messages. I've said that our Kent variant dominates here, but the vaccines are fully protective against this. So when you're called for your vaccine, do go and get that. And really, vaccines are going to be vital to in our fight against the pandemic. And there's no reason that our usual hands, face and space doesn't work against this particular variant. So we just need to keep doing that. It's fully effective against it. It's encouraging that other variants of concern are not particularly expanding in the country at the moment. And that's good news because the variant from South Africa and Brazil, they do have characteristics that actually reduce immunity efficacy. And so we're keen to keep those out of the country and keen to suppress their spread. But again, hands, face and space works with them. And vaccines are already being adapted to the variant first detected in South Africa, which is called B1351. Although it's not actually clear at the moment if and when those new types of vaccines will be needed. So I'm going to stop there. I haven't talked much about the future, but I very much hope that questions will come in that will allow me to do so. And I'll hand over back to Ashley and to Chris. Thank you.
Thank you very much, Sharon. Fabulous talk, and we'll come back to you in a few minutes for questions as we discussed. But now over to you, Chris. Thank you.
Hello, everybody. It's a year now since the World Health Organization declared a pandemic. And at the beginning of next week, it will be a year since Boris Johnson, flanked by Chris Whitty, Chief Medical Officer for England, and Patrick Vallance, our Chief Scientific Officer, stood up at that Downing Street press briefing and said the country was closing for business. Hasn't time flown in some respects, but dragged in other respects? But I remember watching that press conference and this sense of doom descending, because we'd seen what had happened in other countries, and we knew what was almost certainly going to happen in our country going forward. And so we knew what we had in store for us. But we also knew that we would have to find a way out of this. And I remember thinking to myself, we've never made a coronavirus vaccine, full stop. And we've never made any vaccine in as little as 10 months, which was the time actually that it took before the first needles started to go into the first arms in early December of last year. An outstanding achievement. But here we are a year later, and we're approaching the point at which half of the adult population of our country have had a vaccine, and we're aiming by July, notwithstanding what the NHS has announced in the news this evening, and Matt Hancock batted away at the Downing Street press briefing this afternoon, perhaps we'll come back to that in a second, we're aiming that every adult in this country will have had a dose of vaccine by July. And the big question is, will this put us back to some semblance of normality? And what's going to be the future for vaccination? Will it be a one-hit wonder, or will we have to repeat this process year on year? Well, let's just back up a second and talk about what vaccines we do have and how the world has effectively raced to create them. The first one across the line was Pfizer's vaccine. This is using technology from BioNTech, the German company. And the way in which it works, it's a first in class. And although people had for many years been working on what we call genetic or RNA vaccines, they'd never actually made one in a human being. So this was a first on many levels. It was the first way that we sought to vaccinate against coronavirus. It was the first time that one of these vaccines had actually been rolled out in people. The way it works is that they've taken the short piece of genetic code that the coronavirus itself uses to make its outer coat, and specifically the spike that sticks out all over the outer coat of that virus and is the sticky bit that the virus uses to lock onto our cells. And they have taken that piece of genetic code, wrapped it up into an oily droplet, effectively, and they make billions of those. And when you have the injection, the vaccine merges rather like soap bubbles joining together with the lining or the membrane of the cells at the site of injection, and that genetic cargo is deposited into the muscle cells. They can decode the message in there and produce the same thing that the coronavirus would produce for real were it in you. And as a result, you can present to your immune system the spike of coronavirus, but without having to have coronavirus first. And this leads to the production over about 2 or 3 weeks of both antibodies, which are sticky molecules that wash around in the blood and can neutralize things that shouldn't be there, as well as white blood cells called T cells that will go around and prowl around every cell in your body, inspecting what's going on in those cells and looking to see if they have any evidence of a virus in them. And if they do, they nuke them. And in this way, you are thoroughly protected. The protection takes about 2 or 3 weeks to kick in. And the reason it does so is because it takes time to make or decode and make the coronavirus message, then to marshal the various parts of the immune response, and then to make those responses in sufficient quantities so that should you then encounter the virus for real, you're protected. Now, the other major product that's going out at the moment is AstraZeneca's vaccine, of course, very much in the news at the moment with the EU beating itself up all about it. Perhaps we'll return to that in the questioning. The way that works is broadly similar, actually, in the sense that, again, what they've done is to take the genetic code from the coronavirus corresponding to that spike that's so important for the virus to invade our cells. This time, though, instead of wrapping it up into an oily droplet, they've actually put it inside a defective virus of a totally different type. They're using a modified chimpanzee cold virus. It's called ChAdOx for chimpanzee adenovirus, Oxford. This is a disabled virus, so it can't grow in the body. It can only grow in the laboratory. And they have inserted into where the genetic code of that virus would normally be a copy or some copies of the coronavirus outer coat message. And this virus can be grown in the laboratory to very, very high levels, as in about 10 billion particles is how many virus particles you're putting in with the average injection into a person. When it's injected into us, the viruses dock with and use the measures that they would normally use if they were trying to infect you for real to get into your muscle cells at the site of injection. But then history repeats itself almost like it does with the Pfizer vaccine. You decode the genetic message of the spike protein of coronavirus, make it in huge quantities, present that to your immune system, and then you make both T cells and you make antibodies. And again, the trajectory for that happening, it takes about 2 or 3 weeks before you begin to make these things in appreciable enough quantities that you're then considered protected. Now, the trials that were done to prove initially efficacy, those trials really were looking at what we're calling severe disease, because at the end of the day, the striking thing about this coronavirus is that it is not an equal opportunities virus. While it will infect pretty much anybody, it's very selective about who it's affecting badly. Age is the major risk factor, as are things like diabetes and obesity. Being male, 70% of the victims turn out to be male, and we don't actually know exactly why men are more susceptible than women. And there are some other more minor risk factors as well. But given that there is, in the aforementioned groups, a much higher risk of mortality, there's about a 1% mortality overall, maybe as low as 0.5%, it's much higher in the older and sicker age groups, maybe as high as 15%, maybe as high as 30% in some people. But among younger people, very, very low indeed. And we don't know why that is. But the fact is that by getting the vaccine into people, we can convert those lethal cases into non-lethal cases. What we didn't know was whether or not these vaccines could actually prevent infection, full stop, and whether or not they could also protect against things like long COVID. And what we're now learning from trials that are being done in the real world, thanks to the fact that already 17 million people across Europe have had AstraZeneca's vaccine, and across the world, it's millions and millions and millions of people have had these vaccines now. We're gathering data, analysing it, and the emerging picture is a huge success story. Most vaccines that we would settle for as a good bet, like the flu vaccines, for example, if they were 60% effective, we would be delighted. These vaccines are massively outperforming that. Recent data from Scotland, we're waiting for the formal publication, but it looks reliable, shows amongst 1.5 million people vaccinated there, a protection level afforded by AstraZeneca's vaccine of well over 90% of severe disease, and for Pfizer's vaccine of close to 90%. And data from Addenbrooke's Hospital that the Department of Medicine and Infectious Diseases team have produced shows that on staff members, those who are vaccinated have a 4-fold lower rate of just catching the infection compared with those that haven't yet been vaccinated. So it's really delivering on all fronts, and that's absolutely stupendous. But what we don't know, and this is really my nod to where are we going next with this, and we're going to have to learn this, but we can't speed up time. What we don't know is how long will we be protected by these vaccines? We know they're effective in the short term, but how long will that immunity last for? Because the reason for our caution is that unlike, say, measles, which if you catch that, A, you know all about it, B, you might die, but C, you will produce lasting lifelong immunity, coronaviruses are tough customers and they don't produce long-term immunity. People do tend to lose their immunity to natural coronavirus infection after a year or so, maybe sooner in some cases. And there are certainly cases documented of this new coronavirus producing reinfection within short spaces of time. the shortest I've read a case report for is as short as 48 days between a person catching it, recovering from it, and then catching it again. So given that we don't really understand immunity against natural infection, naturally we don't understand what long-term immunity will arise from vaccination. And so that's the experiment we're currently doing. We'll be following up people aggressively to see, once they've had one of these vaccines, how long are they protected for? The good news is that when you have the vaccine, on average, the level of immune response you get in response to these vaccines is many, many-fold higher than if you naturally catch the infection. And that's probably because most people get a very mild course with coronavirus. Half the time they have no symptoms whatsoever. But because you get that more profound immune response to the vaccine, because the vaccine is not encumbered by various immune evasion mechanisms that the virus has got, because it's quite clever and knows how to bypass the immune response, vaccines don't have that problem. That's why you make a more powerful response. We might anticipate that that response might last a bit longer, but time is going to tell. Now let's think about the worst case scenario. If the vaccines don't produce really, really long-term protection, we're going to have some kind of process for revaccinating people, some kind of catch-up, some kind of booster program. Now that sounds alarming at first face value, but actually there's already a really successful way of doing this, and that's called the flu vaccine program. And every year in the UK, we offer flu vaccines to more than 15 million people. It's very effective. We say very effective. It's about 60 to 70% effective at preventing the worst doses and the worst cases of flu. And the way in which that works is that all around the world, samples of flu are being collected and analysed in the way that Sharon is analysing here in the UK samples of coronavirus. And we're watching to see how the virus is changing and evolving and asking the question, are these viruses that are now circulating sufficiently different to sidestep the protection conferred by our present suite of vaccines? And if the answer is yes, then the World Health Organization make a decision to change the vaccine, and they then update the vaccine mix. We make new vaccines, and then they're deployed in the seasonal flu vaccine program. So we already have a precedent for how to do this. We already have the teams capable of doing this sort of thing. So I'm not so alarmed by this. So I'm fully expecting actually, but for the next few years, we're probably going to see a booster program in place, and we'll probably be expecting to be called up to go and get your flu vaccine and possibly your coronavirus vaccine to go with it. But this will depend on how the next few months play out, how the virus evolves and changes further, because it will, and what actually happens to the rest of the world. Because at the moment here in the UK, we're in something of a gilded cage. We've actually got very high levels of vaccination, and we're aiming for 100% vaccination before the year is out. But other countries in the world are not so lucky. And because this is a pandemic with a virus that we know isn't going away, this is an endemic problem, then we're not out of this until everyone across the world is out of this. And that's because all those countries around the world that still have disease activity have the opportunity to breed new variants of this virus. Because where there are high levels of virus turnover, there are high numbers of cases of the virus rolling the genetic dice, as you heard Sharon explain. And that means there's the opportunity for variants that can dodge our vaccines to appear. And so we need to make sure that the world is safe so that everyone is safe. I'll leave it there, and I think perhaps things we could discuss would be what's going on in Europe and what the consequences of that might be, and what other vaccines are soon going to be joining AstraZeneca and Pfizer's suite of vaccines to really probably bring the repertoire to as many as 7 vaccines that we're going to be offered in the future, and what might happen if we run out of one and might have to have another vaccine. Will they work equivalently if we have to do a sort of vaccine pick and mix in the future?
Thank you very much, Chris. And as always, a fantastic talk. And we've got a number of questions coming in from both on Zoom and on Facebook. So if people do have questions, do keep putting them in. I will just, first of all, I'm going to go over to Sharon. So there are a couple of questions that have come in, Sharon. So first of all, how is increased transmissibility determined? How do you work that out? How transmissible a virus is?
Yeah. Well, the first way that you can do this is by simply observing that there's a surge in cases, although that could be explained by other things, such as chance or a super spreader event. So then what you do is you start to look at this R0, this reproduction rate number that we hear so much about on the news, to see what the R0 is in particular populations compared to other populations. So you're looking at R0. So you're also doing modelling. You can also look at the speed at which the lineage is expanding, i.e. how many cases there are. So there's lots of different ways that you can do that. But you can also look at the particular virus that you think is more transmissible and look at it in experimental models. So, for example, if you are looking at its behaviour, does it appear to attach more strongly to the cells that the receptor that we know it uses to get into the cells? So we can look at that particular binding. And a function of transmissibility also may mean that people have a disease for a longer period of time or shed more virus. And so both of those, one or both of those could be a feature of increased transmissibility. So you can look at how long people actually have the virus detectable when you take samples from them, or the actual amount of virus that they're secreting. So there's lots of different ways that you can look at transmissibility. And over time, the evidence has been very strong, with lots of different strands of evidence to say this is more transmissible.
Okay, thanks very much, Sharon. And there is one other question. The Kent variant has virtually ousted all other variants, and one of our questioners has asked why that was. And if you wanted, I think you did cover that, but if you want to just go over that just briefly again.
Yeah. So really, it's because of its transmissibility characteristic. That has made it a kind of fitter virus than other circulating viruses. And so if you can transmit more, then you're going to be more competitive compared with other circulating viruses. And so that's why it's managed to go from 0 to 98% of all cases. It's it's obviously a fit virus. It's interesting to think about the fact that when the virus first emerged, it was actually at that time a very fit virus, because it was able to infect people and transmit between people. And so at that point, because we were all susceptible to infection, it didn't need to actually evolve increased transmissibility. But actually, as more and more people, the landscape is changing so that the population are becoming more immune to the virus. And so the virus is attempting to become a fitter version of itself, and being able to transmit is one of those ways that it does that.
Okay, thank you very much, Sharon. I think over to you, Chris, on this one. There are a number of different people have asked a similar question, and so that is, can you have the first dose of one vaccine and the second dose of a second vaccine? What does that actually mean in terms of your immunity?
The current protocol and the prescription, as it were, by the government policy is that everyone's going to receive 2 doses of whatever the thing they received first was. But that's now, and this may well change going into the future, and it may well change for a number of reasons. One of them may be because there's a supply problem. Another reason it may change is, and I didn't go into this when I was just giving the overview because it's slightly subtle, but many of the vaccines that are being produced, including AstraZeneca's vaccine, the Johnson & Johnson vaccine, the Sputnik V vaccine that's made by the Russians, these are all based on viruses. And although they're disabled viruses that don't grow well in the body or at all in the body, they're nevertheless going to tickle the immune system. So when you're exposed to the vaccine, you don't just make an immune response against coronavirus encoded by the vaccine, you also make a response against the Trojan horse virus that's bringing in that message. This may limit how many times you can have those vaccines going into the future. The government are aware of this, so they're actively pursuing now a research program to test the principle of what's called heterologous vaccination. And this is where you purposefully mix up different vaccines, and you'll have one dose of one and then a booster with a different one. This is not new science, though, and immunologists will tell you that there is a tried and tested path for this to happen along, and it does tend to work very effectively. It's a bit like you learn your lessons in school, and then you sit down and get tested in the exam room, and you answer questions that are different, but on the same sorts of topics as you've been learning, and you actually learn much better because of it. It's similar here. If you stimulate the immune system in two slightly different ways, you tend to produce an even better response than if you just tickle the immune system with the same thing twice. And so I think it's very likely that in the future, we will see the results of the current study, which were announced a few weeks ago now, £7 million initiative to test this very question, and they'll get results pretty quickly for obvious reasons. I think we'll A, see that that works, and B, we'll actually see that there is an active program of doing this very thing in the future with things like boosters, because there will be supply issues, there will be updates to the vaccine in order to react and respond to things like a changing variant landscape, and some manufacturers may be able to produce a particular response a bit more quickly to a particular variant. And it may well be that some people have had a vaccine based on a virus before, so they therefore have a different vaccine construct the next time to avoid a problem with them being immune to the vaccine itself. So I'm confident and very happy if someone offered me the opportunity to go down that pathway, I'd be happy to take it. I don't think it's dangerous or going to work less well. In fact, I think the opposite is going to work even better.
Okay, thanks very much. We have an interesting question that's coming from Bulgaria. Greetings from Bulgaria, it says. Does vaccination during or after a pandemic accelerate viral mutation rates? So can actually the vaccination program itself change the mutation rates?
Would you like me to go on that one, or Sharon?
Either.
Shall I go first, Sharon, and then?
Yes, please do, Chris. Yeah, thank you.
The answer is that anything that we do to put pressure, selective pressure, on any virus will make that virus change. And this happens with the flu. What we're effectively doing when we create flu vaccines is we put up a barricade that basically fends off the flu in a particular direction. And it encourages the virus to change in such a way that it will bypass the barrier that we've erected. And that just stands to reason. If you've got viruses floating around that just by chance, as Sharon explained, have mutated, and there are changes to the virus that enable it by looking a bit different or being a bit more infectious, a bit more stable, growing to a high level in the body, to surmount the barrier that we erect with vaccination, those will become the circulating dominant strain. So we're in a sort of arms race situation now with the coronavirus, because as we vaccinate more people, we are showing the virus what our defences are going to look like. And at the same time, we've still got cases of it circulating in the community. So we're exposing people who've been vaccinated or are in the course of making an immune response to the response to the vaccine, to the virus itself. So there is an opportunity for it to see that and see that emerging immunity and begin to respond. And so that's why there's a motivation to get as many people protected as quickly as possible, to drive down the number of cases as quickly as possible, because the more rolls of the genetic dice we hand the virus, the more potential there is for this to happen. And this is why it is potentially a problem if we have other countries that still have disease courses raging in their countries. And we need to help them, because if we help them, we help ourselves, because we protect ourselves from that happening.
Thanks, Chris. Sharon, did you want to add anything?
Well, just very briefly, that's a very good explanation for why we're tracking so carefully some particular variants of concern, because they do have characteristics that suggest that they escape the immune response, at least partially, not fully, fortunately, at the moment. And it also explains why we need to drive down disease rates, and so that we can try and reduce the number of new variants that are arising with these particular characteristics. But it also explains our surveillance strategy. So we're looking for variants that may be introduced into the country through travel. So particularly looking for variants that may be in people who've been overseas and they're in a hotel quarantine, or they have gone home for a period of isolation. But we're looking very carefully for mutations in the virus that we have circulating in the country. So our own Kent variant, we're looking to see how often that mutates, and watching very carefully to see whether it's developing mutations that could also mean that it escapes the immune response. And so Chris has said it's an arms race, and the more that people are immune to the virus, the more the virus will be attempting to find a chink in the armour, and so that it continues to persist as a successful virus. And so there's more of the story to run yet.
Okay, and I guess building on that, as I say, question regarding the European position at the moment, which is difficult. So, a couple of different questions. One was probably best summarised with: how much of a negative impact do you think the current process in Europe will have, and what impact might that have on the pandemic?
I think there's an informational problem, and the European leaders have had it in for this vaccine from the get-go. I mean, it's been a pretty sorry story, hasn't it? We had two major publications in Germany, Bild, a major daily, and Handelsblatt, which is a financial daily, ran a very, very deleterious headline, which said that the AstraZeneca vaccine was only 8% effective. Actually, they got their numbers wrong, and of course, because the MHRA would never approve a vaccine that was only 8% effective, and nor would the EMA, the European counterpart. Actually, that was the number of people in the trial that were over a certain age, and they just didn't understand how to read a research paper, so they published a completely damaging headline. And then since then, we've had European leaders like Macron and like Merkel making non-positive noises, and in the case of Macron, very, very strongly worded, very negative noises about what actually data shows is a very effective vaccine. So there was already an image problem for AstraZeneca's vaccine, which was adding to the issue of what we dub the hesitancy. I mean, that's a posh phrase for people being concerned, and I think justifiably concerned about a new product that you're asking them to put into their body when it's a new kid on the block. And I don't blame people at all for asking questions. But the good news is that the number of people that we thought were going to probably say no to a vaccine, based on data from America originally, was that maybe as many as half the population might turn down a vaccine. That has changed dramatically, and as many as 90% of people are now saying yes to the vaccine when they're offered it, and in certain age groups it's nearly 100%, which is really encouraging. But when you see situations emerging like what's happening this week in Europe, it again begins to erode trust. And we know that we've got to get very large numbers of people vaccinated and do it quickly. And that relies on public trust. And if you have negative sentiment, negative headlines, and what we think is probably a massive overreaction on the part of the European countries that are choosing to temporarily suspend their vaccination program, it really does shake the confidence of people who might have been teetering on the brink, shall I, shan't I? And that has a habit, unfortunately, of playing straight into the hands of the anti-vaxxers who then amplify the message. So I am quite worried about this, and I've been doing my best to try to disabuse people of the notion. And I think probably a lot of these countries will investigate this week. They will find that actually there is no evidence that this AstraZeneca vaccine is producing anything like the risks that they seem to be reacting to, and they'll go back to business as usual. But a very useful statistic to bear in mind is that, as one commentator on French radio said this week, for every 100,000 people over the age of 50 that you don't vaccinate each day, that's 5 deaths. And I think that puts it into relief.
Thank you, Chris. Sharon?
Yeah, I mean, I am concerned about the situation in Europe, particularly when we know that there are actually surges in the number of cases in several European countries. So my first concern is that, as Chris says, whilst you're withholding the vaccine, people are dying from COVID-19, and with a surge in cases, that's not necessarily turning the corner through an effective vaccine rollout. The other thing I would say is that actually the proportion of variants of concern in some European countries is relatively high. And so to allow cases to surge at a time when variants are actually, the new kids on the block, these are ones that could potentially escape the immune system. This is not a time really to let go of your control. So if variants become a dominant, that would be a worrying situation to all of us. So I believe in the vaccines that we have. I very much hope that this situation is resolved very quickly.
Okay, thank you very much, both of you. So The next subject, general subject I wanted to just flag up are we've got a number of panelists who are asking about people with specific conditions or taking medicines when they've had their vaccine. So if I give you 3 examples of what we've got. So we've got one person who's got a daughter who's 16 with juvenile arthritis, who's potentially been offered a vaccine. Someone else who has a hemoglobinopathy who's been offered a vaccine. Should they be doing anything different to the standard? And then someone else to take a slightly different tack, has had a vaccine and then took ibuprofen for the symptoms post, and is concerned that may have blunted the response in some way. I wonder if you might want to address any of those. I don't know who wants to take that first. Sharon?
I don't know, Chris.
Oh, Chris, sorry.
Yeah, I don't mind, actually. I don't mind. Either of us, I'm sure, would be.
Well, I'll kick off then by saying a good rule of thumb is if your doctor normally advises you to have a flu vaccine, then this is also the vaccine for you. There should be no reason why you couldn't have one of these vaccines, unless, of course, you have a defined allergy to one of the specific ingredients that are in these vaccines. They're not live agents. They're not live viruses. That means that even if you don't have a working or a good working immune system, they're completely safe, apart from the small risk of some side effects, which everybody gets anyway. And the only thing to bear in mind is that if you don't have a fully working immune system, then you can't rely on getting the same response as quickly as someone that doesn't have that immune problem. What I mean by that is you might well respond well to the vaccine, but it might take you a bit longer. You might not respond at all. So therefore, the same surety or certainty that someone who doesn't have that problem will have post-vaccination, you can't rely on that. But the bottom line is, if you're normally protected by things like the flu vaccine, then A, it's safe, and B, then this is a very good idea, and you'll probably respond as well to these vaccines as well. But you might need a bit longer to make the response, and you might need more regular boosting. How do you know, though? Well, the government have actually recently, in the last couple of weeks, announced a new initiative to test this out, because people with certain defined immune suppressing or transplant patients or other diseases that might have an impact on the performance of the vaccine, those people weren't formally included in the trials. And as a result, we just don't know what will happen in those situations. So to find out, there is now an initiative running and people are being recruited into trials to test the performance of the vaccine specifically in those people. We'll know the answers pretty quickly to this, and that will give enormous reassurance to people who are in this situation. And so rather than us using rules of thumb about flu vaccines, we'll be able to say, and in a recent study, it proved that the vaccine was X% effective within X number of weeks. And I think probably the answer will be it is effective, and it's effective quite quickly.
Okay, thank you. Just while we're on the subject of, sorry, just to go on with vaccines, either of you have any insight as to when the other vaccines that have been developed, you alluded to them, Chris, in your talk, when other vaccines, so those from Moderna and Novavax, etc., might arrive in the UK, etc.?
Moderna has been approved and is scheduled to arrive here in the next month or so. The Johnson & Johnson vaccine has been approved and also recently by the EMA, and I think that's mid-year. Novavax's vaccine is earmarked for midway through this year, and that's the one made in moth cells. So you turn into an insect if you have that vaccine. I'm only kidding, by the way. It's quite intriguing technology, because what they actually do is they take part of the coronavirus and put that into a different virus called a baculovirus that infects insect cells. They infect moth cells growing in a dish with the insect preying virus, and this then makes the moth cells make enormous quantities of coronavirus bits and pieces, which can then be purified and then injected as proteins into people, and it's very effective. Again, that one due to deliver later on in the year.
Thanks. And presumably further vaccine tweaks of those we already know, both of you, that those will be able to be developed much faster than all previous vaccines. It won't take another 10 months, for example.
Well, the great virtue of this is that in the same way that with a flu vaccine, when we have to update the flu vaccine, it's not necessary to return to the regulatory drawing board. You don't have to put a whole new application into the MHRA to get your flu vaccine approved. It's assumed that as long as you follow the same good manufacturing and good medical practices that led to the flu vaccine being made the previous year, you've just adjusted it a bit. It's already pre-approved. And that conversation has already been had, and it's been decided that because we've proved the safety, proven the track record, and proven the utility of the current incumbent vaccines, that if they are updated, it would be relatively straightforward with relatively minimal regulatory, sort of light touch regulatory input to produce reactions, vaccine reactions to variants like the ones that Sharon's helping us to discover.
Okay, thank you. Sharon, if I could just go back to you. We've got one very optimistic colleague from CUH who's put the question forward. Could the virus evolve to be less virulent but highly transmissible?
What I would say is that is possible. I mean, and Chris may want to come in here actually as a virologist, but actually other viruses have had a kind of a track record of being mutating so that they become less serious. So it's been postulated that the common cold used to be a long time ago much more serious than it is now, but now it causes very minimal symptoms. And so if you think about it, a virus that is kind of maximally fit from its perspective in terms of transmitting in the population would be something that does very little harm to the host, but actually spreads like wildfire. So I would say that this is possible. We're going to have to see what happens, and it may take years before we see such a pattern. But certainly that is a possibility. And Chris, I don't know whether you would want to follow up on with your virological expertise on that.
Couldn't really put it better myself. I completely agree. And I guess time will tell, but viruses do have a track record of doing this. And it's horses for courses. A really good example actually is Ebola. And if you look at Ebola virus, which obviously very dramatic in us, the natural host of Ebola viruses are bats. And in bats, the virus is relatively apathogenic. They just carry it and they can pass it on. But there are certain types of Ebola that when they get into people, don't make people unwell. One strain of Ebola called Reston, for example, in the Philippines, does just this. You can find farmers who have been exposed to that. They've got antibodies to it, but it didn't kill them. This is an example of how viruses can evolve new lineages that are not necessarily a case of overkill when they jump the species barrier, and they nevertheless have the ability to transmit quite well. And so, yes, I think what Sharon said is absolutely spot on. It's very likely this thing is going to continue to evolve, and probably it's very transmissible already, but could continue on that track, but make people less ill. And that would be in the evolutionary interest of the virus, because then we would lose interest in it in the same way that we don't really have much interest in the common cold. And as a result, common cold viruses, and there are hundreds of them, are very successful on Earth. Because if they were to make too much of a nuisance of themselves, we would do things about them, and this would be actually a negative evolutionary step for the virus. But by being relatively harmless, we leave them alone. And so they take the minimum they can from us, and they get the maximum bang for their buck.
Okay. And I'm just going to ask one last question to both of you. So if there are any questions we haven't gotten to, we'll try and answer them by email later on. But one last question for both of you is the testing and where we should go with testing. So the full text of the question goes with, even with full vaccination, we could still have high numbers elsewhere with large numbers of asymptomatic cases. Can we ever truly get on top of COVID in the UK without universal testing on a regular basis?
That's a really easy question. You can have that one, Sharon.
Thank you so much. I think what testing is clearly crucial, and we need to have testing available in order to control the virus, particularly because much of the disease, around 30% or so, is asymptomatic infection. So we don't know whether that's spreading. So the testing policy that we have at the moment of having very ready testing that can be done very frequently is the right way to get on top of the virus. Combining that with, that will drive down cases. Combined with vaccines, what we're really trying to do is use a combination of vaccines and testing to get our numbers right down. And that's where we need to head. And so testing is going to be around for as long as the virus is. And we know that we're likely to, that's going to become our kind of new normal, if you like. We're going to have to live with the virus. But the other thing I would say is that this particular pandemic has really changed our attitude to testing. So before the pandemic, if somebody had sent you through a piece of kit to take a blood spot or take a swab and send it back through the post, that would have been very, very strange to us. But actually, what we've done is we've adapted our behaviour and we've appreciated how important testing is. And there's been a massive explosion of innovation around testing. So if we do need testing, and I do very much think we do, we've all become used to the idea that testing is important, that we can participate in that testing, it's relatively easy to do, and that it provides us with really useful information to ourselves, to our family and friends, to know that we are or aren't infected, so we can behave in a way that protects other people. So I hope that answers your question, that really I think testing is here to stay. It's a vital part of our control, and I'm glad of it.
Okay. Well, thank you very much to you, Sharon. Thank you very much to Chris. It's been a fabulous hour, two very, very good talks and brilliant responses to the questions. So I think a huge virtual round of applause, I'm sure, from everyone on Facebook and Zoom. And thank you very much, but fabulous. Thank you very much.
Thanks, Ashley.
Good evening.
Thank you so much. Thanks for having me.
See you soon.